Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adam. This episode features expert answers to your questions on PrEP in transgender individuals and racial and ethnic minority men who have sex with men. I'm joined by Dr. Hazra, who is an assistant professor in the section of infectious disease and global health in the Department of Medicine at the University of Chicago, and Dr. Ofole Mgbako, who is an assistant professor of medicine and population health at the New York University Grossman School of Medicine in New York, New York. For the full online educational program, including video roundtables, downloadable slides, and other podcasts in this series, please visit the link in the show notes for this episode. Now let's get started with our first question from the audience.
Asia asks, what is the clarity and certainty of scientific research when it comes to drug-drug interactions with PrEP, with both feminizing as well as masculinizing gender-affirming hormone therapy?
So, I can start, and Ofole, please jump in, because I know you have a lot of experience in New York City with this as well. I think the first thing to really recognize is the majority of drug studies done, not only around PrEP, but really around any drug, is not recruiting, obviously, folks who are on gender-affirming hormone therapy. So the data from phase 1, phase 2, and even phase 3 studies oftentimes are not including this key population. I will say that is changing, specifically around PrEP and the newer modalities of PrEP, both for cabotegravir for injection for PrEP, which had clear recruitment of gender diverse folks, as well as now newer agents like lenacapavir for PrEP, with specific study designs recruiting these populations to look for potential drug-drug interactions with gender-affirming hormone therapy. I think there were concerns specifically with tenofovir, which is a component in both TDF-FTC as well as TAF-FTC, are two oral options for PrEP. That impact specifically estrogen levels in folks taking feminizing hormone therapy. I do think the data can become more clear now that is not the case, and that there are no clear drug-drug interactions. But when caring for transgender, gender diverse folks, it's really important to validate these concerns and recognize that these older studies being done on these drugs did not really take into account the lived experiences and the medications taken by this population.
No, I completely agree. And I think it was follow-up analysis of the Discover trial that showed for both TDF-FTC and TAF-FTC, for folks in that study who were on gender-affirming hormone therapy, the levels of TDF and FTC were pretty much stable throughout the study. And so we have those pharmacokinetic studies, we have those outcomes that we can reliably counsel our patients as they come into care. And not only counseling them on the fact that it's safe, but also one thing that Anu mentioned is really trying to integrate our services. So one thing we try to do in New York City is really think about, as we recruit patients into our clinics and into our system, and we're trying to provide gender-affirming care, and we're starting hormone therapy, doing that together with PrEP, making sure we're offering those at the same time so that patients feel safe and are in an environment where they know that we can give HIV prevention services and gender-affirming care services together in a model that makes sense for them.
Great. The next question, Kevin asks, do you think that heterosexual Latino and African American communities have fallen by the wayside because we as prevention workers have focused for decades on the LGBTQIA communities, therefore leading to less grant funding for heterosexual communities for PrEP?
It's a great question. It's really complex how we design our spaces, how we design our outreach and other kind of services that we're offering. I think in New York City, we really made a concerted effort over the last few years, particularly when it comes to cisgender women. When you're on the subway, you see advertisements. When you're, waiting for the bus, you see advertisements, kind of really spreading that out and then making sure we're reaching out to specific community groups and we're reaching out to specific women's health clinics to try to integrate PrEP care. I think for heterosexual men, we really kind of have to also think about targeted messaging and outreach. And in our work here, we've really tried to partner with community-based organizations and really kind of partner with folks in non-traditional settings who can kind of get the word out about PrEP, because it really just takes a concerted and consistent effort to make sure that everybody knows that this is a tool for them and that this is available to them, and that we have the evidence and the science behind it so that folks can feel protected. So I think that there's always work to do in terms of making sure that our outreach is, targeted at all sorts of communities that continue to be at risk for HIV.
Yeah, no, totally agree. I mean, I think as a whole, the understanding really has recognizing that cisgender women have really been left behind in the past decade in the PrEP conversation, and that I think is a huge oversight. And that a lot of folks like Ofole and myself and people across the country are really working to amend, and that means recognizing where do women get healthcare and making sure that PrEP is integrated in those centers. That women may not come to a PrEP clinic, may not come to a large LGBT health center where PrEP is being implemented, but they are seeing their own providers, their own women health doctors. So it's about how do we increase education and access in those spaces, like Ofole mentioned, that patients are already accessing care, already there. I think the updated CDC guidelines, I think, are also pretty powerful in how they talk about PrEP really should be discussed with anyone who's sexually active. So that doesn't matter who they are, but like if you are having a conversation around sex, you're clearly talking about STIs or screening for STIs. If you're talking about that, then you should talk about how are you protecting yourself from HIV, and that there is a medication out there that can reduce your risk of HIV by 99%. And when you open or frame it that way, oftentimes folks are really surprised and don't even know that was even an option for them. And oftentimes, again, feel that empowerment to then think about ways to protect themselves in through this. And again, I think there's a lot of work to do to sort of integrate sort of PrEP access across the board beyond just LGBTQI populations, but still within LGBTQI populations, there's so much work to be done specifically in further racially minoritized or ethnically minoritized groups.
Great. Tess asks, has there been any movement such as research, ongoing proposals to make FTC TAF accessible to trans men and cis women, since it is currently only available to those assigned male at birth?
Yeah, a study called Purpose One, which is looking at not only the efficacy of lenacapavir, which is one of their long-acting PrEP agents, but also at TAF FTC and TDF FTC, essentially comparing it to those oral options. And Purpose One is specifically looking at cisgender women and folks assigned female at birth. So we will hopefully have that data. I will say people are prescribing TAF FTC to trans men who only report anal sex, and you can consider that an off-label use. But again, thinking about shared decision-making and understanding risk benefits in those patients. Again, the sticking point is really thinking about tissue concentrations of specifically tenofovir in the vaginal and endocervical mucosa, which is still sort of up for debate. That's why the concerns around TAF is still there. And I'm hoping Purpose One will help elucidate that, but we're still waiting on that data, unfortunately.
Yeah, I think it's a great question, and it's always so important to bring up this community. I think building on what Anu's been saying, the trans masculine community has really, and the trans community in general, has really been advocating and fighting for inclusion in terms of our research agenda and our outcomes. And the erasure and the kind of lack of inclusion really sets us all behind. And so I think that concerted pressure, that advocacy has really helped, but is still very much needed by all of us, particularly healthcare providers, to know how to give the best care that we can for our patients. And I think that that's been, heard, by the CDC and, others doing this research. But certainly we need to continue that pressure because it's important to give the best care for these populations.
Nicole asks, how long should oral PrEP be used before switching to injectable long-acting CAB?
Yeah, it's a good question. So basically, it's now optional whether you want to start with what they call an oral lead-in before injectable cabotegravir, or if you just want to start injectable cabotegravir without the oral lead-in. And so that's really based on shared decision-making with your patient. In our setting, a lot of patients, that we have on injectable cabotegravir have already been on oral PrEP before. And so, like a lot of them feel comfortable starting it and then are continuing it and then having a nice transition into injectable PrEP. But then we have a population of folks who haven't been on it before. And I think after you start it, it's really kind of having that system in place for monitoring the labs, making sure you're supporting your patients to come in for their subsequent injections, and so on, and really kind of providing that support for retention and adherence. But it's essentially optional. And then patients who kind of fall off the scheduled Q2 month injectable cabotegravir, we're navigating here, kind of making sure folks are protected on oral PrEP, if they have that lapse or if they miss their appointment by a period of time. So really it's shared decision making, and it's making sure that patients are protected on either oral or injectable PrEP.
Yeah. And I would say what I often come across is insurance access for injectable PrEP can be a bit cumbersome. And so oftentimes essentially someone's coming in to start PrEP and they're interested in injectable PrEP. I say, we can get you injectable PrEP, probably not today. So let me bridge you and start you on something today since you're here. And then we can get you back once everything is through to get you access to injectable PrEP and then start.
Okay, Asia asked a number of questions. I'm going to kind of paraphrase these, but the first one is post-op trans women and men and PrEP use. How long after surgery should they start, and how long after that they do start is PrEP effective? Are there resources on trans feminine and trans masculine differences?
Yeah, so the PrEP effectiveness has little to do with I think how far folks are from post-op. It's more of what parts of their body are they using for sex. And so I think that's thinking about it that way gives you a better idea of PrEP effectiveness. I will say the data that we have specifically with TDF, FTC, so the oldest oral version of PrEP that we have, is quite dated and probably really conservative with their estimates. But the estimates still are what we sort of say to patients that at the rectal mucosa, it's about 7 days before we expect to see full protection with PrEP. At the vaginal and cervical mucosa, we're looking more at about 2 to 3 weeks, really, until we get general effectiveness. For neovaginal tissues or neovagina, there's no real data, I would say, from time to effectiveness. Or at least I haven't. And Ofole, please jump in. But for neovaginal tissue, I don't think there is a good data to say when is PrEP effective. But I think we also recognize that on-demand or 2-1-1 PrEP is effective for both cisgender men as well as transgender women. And so I think a lot of us have extrapolated that and say, while we say 7 days for rectal mucosa, it's likely shorter than that. But if folks want what is the most conservative estimate, it's still considered to be 7 days until protection at the rectal mucosa, 2 to 3 weeks really at the vagina, regardless of your identity or your post-op status.
Yeah, I completely agree, Anu. And going back to the points of making sure you remain in contact and good contact with your patients in terms of their sexual activity and what they have planned around their surgeries, and kind of just making sure that they know the different options in place for them to stay protected is the most important. But we definitely need more data in that area.
And I'll plug, and you probably are, the person asking the question is probably already aware of the National LGBTQIA Health Education Center. They have toolkits specifically for trans women as well as trans men with pre-exposure prophylaxis. So trying to compile the data available to date, some of the information that Ofole mentioned at the beginning about the post-hoc analysis from Discover to look at the efficacy and impact on hormones. But that tends to be sort of my go-to. But yeah, that's what I'm aware of.
That's great, because the next question actually had to do with resources. So that's perfect. But they also did ask about resources specifically dealing with the PrEP stigma for trans people. Do you have any resources for that specifically?
It's a good question. Yeah. So here in New York City, the New York State Department of Health has tons of wonderful resources around this. And I've seen it being used outside of New York. And this is actually, I think, currently PrEP Aware Week. And so there's a lot of materials and short videos being sent out that are really wonderful. Actually, we reposted it on my, I guess, X, it's called now, the other day. And they have kind of 8 global ambassadors of all different identities kind of talking about their experience with PrEP, and that really PrEP is not just about these kind of like hard clinical outcomes that we talk about, but It's also about liberation, right? It's also about sexual satisfaction and freedom. And that's really how we're going to address the stigma of it and really kind of make sure that it's reaching all different communities where they see folks who look like them. So I think it's prepweek.org, but the New York State Department of Health has a lot of wonderful resources, as does NASTAD. NASTAD has like a lot of great resources, particularly for frontline clinicians, and everything from stigma toolkits to issues with billing and coding when it comes to PrEP. I
was going to plug NASTAD. I think they have, I don't know if they have a toolkit specifically for trans and gender diverse folks, but I know they have a lot of toolkits on how to scale up PrEP in your practice. And then logistical issues that a lot of providers have, like what billing code should I use, or how long should I structure my visits to be, things like that, if you're really brand new to creating a PrEP clinic or whatnot.
Great. And then they also ask, what are some good examples of integration of gender-affirming care and PrEP care? And do you think that is a good strategy?
Yeah, I mean, I think co-locating services is hugely important. And for my transgender diverse folks living with HIV, I try to co-locate both their HIV services and their hormones so we can talk about everything at once. I think the fewer number of appointments someone has to make, the fewer number of call-offs from work or trying to take transportation to clinics, the better. I think there's a lot of great models out there that have been able to co-locate gender health services with sexual health services. In New York City, it's a great example. Large LGBT health clinics have been doing this for a long time. Calum Lord in New York, Whitman Walker in DC, Howard Brown in Chicago have been really thinking about sort of unifying these services all in one. And so it's just a one-stop shop where you can get your gender services, your sexual health services, STI screening, and PrEP all in one go.
Yeah, completely agree. And from an implementation perspective, something that we've thought a lot about here is how do we start to break down the silos between the hospital, the clinic, and the community. And so we have a fabulous partner organization that we work with called Destination Tomorrow, which services the LGBTQ plus community with, a specific kind of focus on trans individuals. And we have a wonderful relationship with them and have kind of set up a referral system where they know our PrEP navigators. And so if they are providing services to a client in the community that, shows that they have an interest in PrEP or have been counseled on HIV prevention options, they know that they have a partner in our clinical setting that they can send that patient to, who we can do a warm handoff and make sure that we're co-locating that therapy. Just like Anu said. So I would just also advocate for folks in clinical settings to really try to think about what new and interesting community partnerships that they can start, because I think there's a lot of solidarity there that could be built and a lot of trust building that happens on the patient side when they know that an organization in the community that they really trust has a wonderful relationship with this clinical setting that's very new and can be very intimidating to them.
Great. Kevin asks, considering the South and Southwest regions have seen a 57% increase in new HIV infections, what do you think we need to do better in those regions?
And it's access. I mean, a lot of those are what Ofole mentioned, these structural inequities, and structural problems require structural solutions. And so that it requires a lot of advocacy and really activism on the ground. We know that PrEP access is under threat currently under sort of legislation like the Sarah Burst Braewood in Texas, which will go up to Supreme Court, if not this session, but the next. And that will really, I think, strip a lot of access to PrEP across the majority of the Deep South. And I think this is becoming more and more of a political issue. And it's important for us, again, to pass a national PrEP program that is really advocated by organizations like PrEP for All, that has been doing a lot of work on the Capitol Hill to make sure that we're able to really, again, create a federal program to help support states and other local agencies to increase PrEP access. But again, I think the PrEP to need disparities that we're seeing are really, I think, an indictment of these structural inequities that we see across the country. We can continuing access to education and these initiatives and making sure that we're funding clinics and sites in the South and Southwest regions are so important. But at the end of the day, like, we need to be able to actually then also advocate to integrate these services and make sure these services are invested in by these states as well.
Yeah, I completely agree, Anu. And I feel like we're at this very precarious moment, right? Because you have not only the challenge to the legal challenges to PrEP access, but you have really across the country this backlash against the existence of LGBTQ plus people being enshrined in policy, whether it's trying to ban drag shows or ban certain books or ban this and ban that. And so it's really, important for us as healthcare providers, not only to use a kind of, our voice in our local communities, but really to create those connections with folks across the country. I think in New York City, we have a very kind of progressive infrastructure when it comes to allocated resources from both the city and the state. But in certain parts of the country, in the South and Southwest, that might not be the case, right? So how do we kind of share expertise and resources? How do we learn from each other, and how do we advocate for each other, not only on the national level for a national PrEP program, like Anu mentioned, but also for on the local level, and really kind of create that network of solidarity. So I think it's gonna take being really vocal in the setting of this backlash, and then also really creative and innovative to think about models of care that are sustainable in spite of a lot of the challenges that we see, both legal, social, and otherwise.
All right. And we have another question about concerns about drug-drug interactions, which you did address, but also how do you approach concerns about side effects with patients starting PrEP?
Yeah, so for me, it really depends on the type of PrEP that they're interested in, and then also their profile as a patient, right? So someone who's generally young and healthy and not on any kind of other medications, that conversation is going to be much shorter, right? But I, often bring up what they probably heard, right? That with TDF FTC, there's a concern about kidney and bone effects. But we know that in folks who are, generally healthy and aren't taking any other medications that have an impact in those two areas, that we're pretty safe to start, and that the reason that we are doing lab monitoring frequently is to make sure that if we see something pop up, that we can address it. For folks who have chronic kidney disease, or folks who have a history of fractures or history of bone disease in their family, that's definitely a discussion, and letting them know that we have other options that kind of lessen that risk is part of the conversation. And then in terms of injectable PrEP, it's really making sure that folks know that pain at the site is something that they will experience because it is an injection. So really making sure, because something like fear of needles really kind of comes up a lot in some of the studies out there that have been done with patients and their perceptions and kind of concerns around injectable PrEP. So making sure that they know that is potentially an issue, and that we're offering pain control. And that moving forward, it's really kind of making sure that if things like tuberculosis disease or something like that comes up, that we can shift our strategy in terms of what we're treating, given kind of known interactions with some of the parts of PrEP, with some of parts of anti-TB therapy, for example. So really, it's an ongoing conversation, and it really depends on the patient.
Yeah, perfectly said. I have nothing else to add.
Great. And then Nicole asks about counseling patients on transmission risk. Can you talk a little bit about how you do that?
Yeah. When we think about sort of transmission risk of HIV, we know what confers the highest risk of transmission, and that's oftentimes bodily fluids that can carry HIV, which include specifically semen, blood, vaginal secretions, rectal secretions, or any other bodily fluid that's contaminated with blood is the highest concern. When we're thinking about HIV transmission risk, oftentimes in these settings, we're talking about sexual transmission risk. And so it's important to also then debunk sort of misconceptions folks have about HIV transmission through like kissing, saliva, sharing bathrooms or toilets or cups or whatnot. We know that these are not ways that HIV is transmitted. But I think it's important, that I always think about it as also when you have someone coming to you for an STI, let's say rectal gonorrhea, and they're HIV negative, I think it's really important to have a PrEP conversation at that visit, that you treat them for their STI, but then also recognize that that a single bacterial STI confers an exponentially elevated risk of HIV acquisition in that individual. And so this is a great opportunity to actually talk to them about, we're treating you for this STI. Have you thought about how to protect yourself against HIV? Do you know that there's these options that can really reduce your risk to almost zero to acquire HIV? Let's talk about what you might be interested in. And I think, again, really making sure that PrEP is part of all of these conversations is the only way that we can really start to scale up our prescription and understanding of it.
Yeah, I completely agree. And one thing I love about what Anu said during the presentation earlier is thinking about how we use the term risk and how we think about the term risk, particularly as providers. Anu and I are of a generation where folks grew up afraid of sex, right? Because you can get all sorts of diseases, you can get really sick. And that was the message that was given to us as we were developing as young adults. And so that's what a lot of our patients received, right? So trying to think not only about risk of HIV acquisition and making sure that's a part of the conversation and the initial counseling, but making sure that folks know that ask the question, what does sexual health mean to them? And really trying to get them to a place that's free of shame and free of fear, but is centered around pleasure and then centered around health. It's really important, I think, that we start to shift that conversation, because clearly, I think we've done a good job increasing our number of PrEP users and PrEP coverage, but the inequities are still there, right? And the people that feel the burden and the force of all of the things I just mentioned are often trans folks, often people of color in the LGBTQ plus community. So we have to start bringing that into the conversation. Issues of freeing someone and issues of liberation when it comes to sexual health, and not just decreasing sexual risk of HIV.
Great, thank you. Kevin asks, considering provider stigma that you discussed in the introductory part of the presentation, do you think it's wise for PrEP navigators and prevention workers to coach clients who are interested in PrEP?
100%. I think peer navigators are hugely helpful in the implementation and scale up of PrEP across the board. We depend on peer navigators in our PrEP clinics. Oftentimes they have a bit more time to talk about PrEP and the PrEP options with patients themselves. Oftentimes they're able to connect with patients as more near peer to them about these options. I think that the problem is they need to be funded. Like, you need to pay them, right? And so what they're doing is not generating quote unquote revenue for your medical system. And so so you need to be able to actually acknowledge the benefit that they provide and then compensate them properly. I've come across so many PrEP navigators and peer navigators that essentially are forced to work very much for free or really not given what the worth that they're doing. But the problem is they're not able to bill for their services, which is why a lot of clinics end up saying they can't afford them or utilize them. But 100%, I think having those types of ancillary staff and support staff is hugely helpful in trying to sort of, again, promote and push PrEP prescription. And like Ofole mentioned, really reconceptualizing our understanding of sex from a fear-based understanding to a pleasure-focused understanding.
Yeah, I think that's perfect. What Anu said, our PrEP navigator here is just so central to the success of our outreach strategy. And people go to her for all sorts of things, not just related to their PrEP and their medical care, but just their life, right? And trying to navigate questions about social needs, which is a huge part of the conversation, right? Because this care that we give around PrEP is given in a context, right, of people struggling with all sorts of social determinants of health in their lives. And so PrEP navigators, I think, end up being hugely important because of that, because they serve as a resource in folks' lives to help them persist in PrEP care, because they're able to think about and address some of the other issues. And the identity of that person is so important, right? Someone who, our PrEP navigators bilingual, right? So then we have a large population here in New York City of young folks who are recent immigrants to New York City or bust migrants from the South to New York City. And so having someone that speaks their language, who understands what they're going through is really important. So those navigators, I think, are really central. And, I think it's important to, and you mentioned this as well, think about cost and cost effectiveness and really trying to lay out the case, right, for the benefits of these navigators in your system, right from when you hire them and bring them on or when they start their work, right? It's trying to build those models and build that case for hospital and clinic leadership.
Asks, this is a specific case scenario. So a female patient at risk for HIV has AKI with a creatinine of 2 and a BMI that's greater than 35. Would you do FTC TAF or consider cabotegravir in this patient?
This is when shared decision making comes into play. I think. I think it's when you're saying this specific clinical condition has not been clearly studied in either clinical trial, but we do this all the time. I think it's important to recognize that like these discussions are not unique to PrEP. I mean, we have discussions on shared decision making for all these other medications that we often use off label or maybe not exactly the way that they were studied. But making sure that patients understand that and having that risk benefit discussion with them. That cabotegravir has been studied in folks assigned female at birth really well and shown great effectiveness, in fact, even higher than oral PrEP in those populations. But we know that after a certain BMI point, the concerns around pharmacokinetics and concentrations of the drug can be declined, but we can also overcome that by using larger needles, 1.5 to 2 inch needle, when you're delivering cabotegravir, but that can often be a bit more painful and may result in more nodules forming versus TAF FTC, where everything that we know so far from like animal models say that it should be fine in people assigned female at birth, but we just don't have that clear-cut randomized controlled trial data. And so again, just making sure they're having this conversation with the patient feels like they're part of that discussion, and then they can. But either way, you're providing some benefit against HIV, and that's probably the most important thing to take away. But making sure the patient understands like what the risk benefits are, and you guys together can come together with some sort of treatment plan.
Yeah, I completely agree. And if they have a current AKI and they're dealing with that, I would clearly steer away from the TDF for that moment. But I think what Anu's pointing to is like there's no right answer, and the answer can change depending on patient preference and depending on their specific clinical profile at the moment. And so I think making that clear too, that there's no, like, once you choose one, it's not like, oh, that's your final answer and you can never switch. Presenting it as a menu of options, and we can choose this for now, and let's continue to readdress it as we move forward, as we closely monitor things and keep you in care, is the best, I think, way to think about it versus what's the right multiple choice answer. Because I think our patients often feel that. And if they feel like they don't have, that plethora of options and that that it's dynamic and it likely will change over time, that might close them off, right? So it's important that they feel that this is a dynamic process and you're on that journey with them.
We had a couple questions come in about doxy PEP and whether you are doing that along with PrEP, and then whether you are also doing that for trans masculine individuals as well.
You want to start with this one, Ofole? I can follow up. Yeah. Why don't you?
Sure. Yeah. So doxy PEP, so it's in our setting here, it's really provider dependent so far. I don't think we've settled on a system-wide approach. So it's still provider dependent as the CDC settles on its guidelines. They're taking feedback, from providers around the country on it now. But yeah, I know some providers who it's a really important part of their care delivery and their conversations with patients. And then some who are really waiting for those formal guidelines to come out and are much more cautious with it. So in our setting, it's really still very much provider dependent. And I'm sure that will change moving forward as we have more discrete guidelines and have a good sense of which populations we want to think about doxy PEP in.
Yeah. And so everyone's on the same page. Doxy PEP is an intervention that has been studied again in people assigned male at birth and cisgender men and transgender women who sex with men, that taking 200 milligrams of doxy, ideally within 24 hours after commonless sex, can reduce their acquisition risk of gonorrhea, chlamydia, or syphilis by in the order of 60 to 70%. So it's a significant, risk reduction, and really compelling data that a lot of clinics have started to implement, like Ofole mentioned, ours as well in Chicago, thinking about, again, co-locating these services. You're thinking about HIV prevention, thinking about STI prevention. These sort of really do go hand in hand. And so we've been trying to do that or scale that up really well here at Howard Brown and at U Chicago, with the idea is like, we don't want to make the same mistakes we made with HIV PrEP, with these inequities where we're getting sort of folks on PrEP are not really folks who maybe need to be on it, and people who really need to be on PrEP are not getting access to it. The question on trans men is really interesting. And I think that has been something, again, that has come up significant, like thinking about, again, are people assigned female at birth being left behind with another sexual health intervention, another biomedical intervention, and we're sort of not able to really provide them some satisfactory result. I will say that certain places around the country, specifically San Francisco AIDS Foundation, is now, creating the protocol for doxypep in transmasculine folks. We are, watching that, at least here in Chicago. I have a few transmasculine folks who are on doxypep who've had multiple rectal STIs. And this is something, after shared decision-making, talking about risk benefit and a clear informed consent with them to think about for them. But again, I think doxycycline is something that we prescribe across the board. And it's important to sort of be able to recognize the benefits of it and how that might fit into the patient in front of you.
Great. We had a couple different questions about adherence and retention. So a question about recommendations to maintain medication adherence to PrEP. And then do you have any suggestions for retention for those on injectable PrEP as well?
Sure. Yeah. So I think going back to our initial slides and how we started the conversation, I think it's really proactively addressing what we know are barriers, right? Which we previously mentioned. But one thing that we've been doing here that's really important is proactively addressing social determinants of health as well as psychosocial determinants of health. So screening patients when they're linking for PrEP care, whether that's oral or injectable PrEP care, screening them for depression and anxiety. And we actually have a clinic-based social determinants of health screener embedded in Epic that's completed by our support staff and our patients that outlines, okay, are there issues with housing instability? Are there issues with food insecurity and childcare and the like? Because we don't necessarily need further data to show us that these are the reasons that people fall out of PrEP care. We know that these are the reasons folks fall out of PrEP care. So I think we have tried to really proactively address those things and then use an embedded psychologist and our navigator to really help navigate those patients to services that they need in the community. And so some of those services that we can address on site, whether it's legal aid. Here at Bellevue Hospital, we actually have a legal aid clinic, which is really wonderful. And so we can refer patients to our legal aid clinic. But then also going back to what I mentioned before, those community partnerships, navigating patients to community partners that either specialize or have expertise or have resources in the area that they need, that they have health-related social needs. It's really being proactive about those barriers that we mentioned, because if not proactive, then you're reactive, and then it's patients falling out of care and then trying to catch up on the reasons they fell out of care. If you guys have other approaches where you are.
Yeah, I think that adherence piece is important. I mean, specifically thinking about a daily medication for our patients who are maybe younger, they may not be on a daily medication or anything like that. So trying to build in sort of adherence counseling from the very first PrEP visit onwards. And then understanding that there are options. And again, going back to the fact that people should feel empowered by having more options to PrEP. So if they are forgetting doses, maybe an on-demand PrEP dose is something that might be right for them. Or maybe injectable PrEP in that regard might be right for them. Or maybe what we are seeing in the future, like implantable PrEP or longer acting PrEP or whatnot might be options for them. So I think, again, just my adherence counseling is mostly based on at the very beginning saying, hey, this is probably going to be the first time you're on a daily medication. What are your strategies to make sure you're able to take your medications every day? And we understand that while PrEP is highly effective, that effectiveness is linked, directly with adherence. And so if you're missing more than 2-3 doses a week, that effectiveness of PrEP often drops significantly. So making sure patients understand that from the get-go and being able to do sort of ongoing adherence counseling and figure out strategies to either improve adherence or thinking about, again, now we are living in a time where we have more options to provide them to make sure they can be retained in care.
All right. Ellen asks, Dr. Mgbako, can you talk more about your PrEP Navigator team member? What does she do and how does she engage?
Sure. No, she's Absolutely fabulous. And so she is well known to our community partners, and then just knows our system so well. And so knows how to navigate people to resources within our system, and knows how to navigate folks to HIV care if they become HIV positive. So she just knows the system really well. She's a Latina cisgender woman. And so her identity is really important. And as I mentioned, her being bilingual is really important. And she's done training, right? Training in structural racism, training in transgender care, and doing that specific training on top of, I think, just being a wonderful person has really allowed her to independently be a source for our patients to stay in care. She's kind of their go-to for a lot of issues that come up. And she's even incorporated a time each month that patients can just drop in if they want to talk with her, or just want to spend time with someone, understanding the kind of epidemic of social isolation that a lot of our patients feel. And then she's also proficient in the medication assistance programs and navigating that. So really having someone who's well-trained, both on the clinical side, the system side, and the community side, has been a huge benefit to us. And we really see that reflected in our patients. So yeah, I think without her, we would definitely be in a different place.
Thank you very much to our faculty, and thank you to our listeners for joining in. As a reminder to view the full Paths Forward in PrEP, Overcoming Barriers to PrEP Engagement in Principal Populations program on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.